The next session is Special Lecture 1. This session will be chaired by Dr. Masao Omata. Doctor, please.
Yes, we are inviting the Shiv Sarin from India. Hello, Shiv. How are you?
Yeah.
Then
Thank you.
today he will address the issue on the portal hypertension in hepatocellular carcinoma, and he obviously he's running the very active liver hospitals ILBS in India. I just visited his institute about a week ago, and so maybe just interest of time, I may skip some of the introductions, but he awarded the Henry Bocas Gold Medals 2017 and his international recognition awards, which indicates how actively he's been involved in this field for many, many years. So, Shiv, please start your lecture.
Thank you, Professor Omata. My pleasure and honor. The session is being chaired by you. I have sent my video recorded message. Please. Greetings from ILBS. I would like to thank Professor Uno and the organizing committee for having invited me to this very important single topic conference of APASL. I really wanted to come to Sendai but could not come. My greetings and best wishes. I have nothing to disclose. I will try and cover the management of portal hypertension in HCC in next few minutes. The assessment of portal hypertension and the management are both important aspects. The pathways of development of HCC and portal hypertension in a cirrhotic have something in common. There is an increase in the intrahepatic vascular resistance due to fibrosis, and this leads to increased vascular tone and decreased nitric oxide relatively. There is increased splanchnic flux. Finally, a overflow of the blood comes, and this is resulting into portal hypertension. There is an opening of collaterals, angiogenesis develops, there is a chronic inflammation. These two also are the cause for development of HCC. And of course, cirrhosis is an immune suppressed state. Development of HCC is also because of the increased production of EGF, PDGF, and immune suppression. How do we assess? Because fallacies are there. Please remember, due to vascular invasion, portal hypertension increases and HVPG may not be reliable. Liver stiffness measurement may not be reliable. Normally, we say a stiffness of liver of more than 25 kilopascal diagnoses clinically significant portal hypertension. But this may be overdiagnosing because of vascular invasion. Also, spleen stiffness may be fallacious due to portal vein thrombosis. Hence, in every patient of HCC and cirrhosis, please do endoscopy and also see that platelets, even if they're above 150,000 or LSM is less than 15, endoscopy should be done. Treat all HCCs with LSM about 25 with beta blockers. It means there is a high portal pressure. You can start beta blockers in them. This is a famous Japanese classification. You have a VP1 in the peripheral branches, then you have in secondary branches, which is VP2, in the main right or left branch is VP3, and then in the trunk, that is VP4. Patients who have got a VP4 thrombosis have nearly 80% mortality in 1 year. This has to be remembered, and therefore treating portal hypertension and portal vein thrombosis is very important. Is this which patient will develop variceal bleed? Those who have got portal vein thrombosis. Then development of esophageal varices is seen in nearly 38%. High risk varices are present in about 23%. Gastric varices are also present in more number of patients and portal hypertensive gastropathy. But mainly esophageal and high risk varices are there. We have to prevent the development of portal hypertension. Now here, those patients of HCC with chronic liver disease due to hepatitis C, those who received propranolol along with treatment for hep C, even for 5 years, the HCC occurrence rate was lower. In a patient with cirrhosis who has got hepatitis C, if you give no propranolol, development of HCC is 5 times more. So giving beta blockers prevents development of HCC in hepatitis C. There is an effect of beta blocker on incidence of HCC. As I told you, patients who have got beta blockers versus no beta blockers, incidence in all types of cirrhosis is 13% reduced. Propranolol has very limited benefit, or timolol. The best drug is nadolol, or even better is carvedilol. So a patient with cirrhosis who has not developed HCC, give carvedilol to prevent development of HCC. Now, the development of HCC, disease progression on beta blockers versus no beta blockers, there is a significant difference in these patients. So HCC development is more. Furthermore, when you compare beta blocker usage with non-beta blocker usage, overall survival in a patient with HCC is far better when you give beta blockers. So a patient with HCC who is on beta blockers, survival is better. Then selective versus non-selective. So selective beta blockers versus non-selective. Non-selective is far better than selective beta blockers. And this is to give you an idea from Sweden in a very large series of patients of 2,100. Patients of HCC who received non-selective beta blockers have reduced mortality by 42%. And this is more true when you are using lipophilic rather than a hydrophilic beta blocker drug. So let's understand a patient who has come with HCC. Now he has an LSM of less than 25 or up to 25. Then everyone you will do screening endoscopy. After doing a screening endoscopy, if there are no varices, well, then you manage them. If there are varices of any size, irrespective of small or large, irrespective of esophageal or gastric, you will put this patient on carvedilol. Now, if the patient has any contraindications or intolerance to carvedilol, such patients will be going on to band ligation or cyanoacrylate glue injection. So remember, patients with HCC need beta blockers if there is any amount of varices. Beta blocker therapy reduces incidence of development of HCC and also risk of first bleed and mortality in HCC. So managing portal hypertension, giving beta blockers is important in an HCC and cirrhosis. Now, a patient of HCC, portal hypertension comes with acute variceal bleed. Before that, you would remember a prophylactic part. This is an important study. Now, in patients, if there is a portal vein thrombosis, the blood flow to the liver is reduced. 34 patients of HCC with portal hypertension, 21% had PVT. Now, in these patients, if you have done a EVL, it is better than beta blockers because it is an acute bleed. In these patients, having given beta blockers in acute bleed has no relevance. So every patient who has acute bleed must have EVL done. Now, can you do some more in the prophylaxis part? I told you if the patient has esophageal varix or a gastric varix, regardless of size or red color markings, beta blockers are given. In acute varicose bleed or a patient who was getting treated with immune checkpoint inhibitor or for HCC, he develops bleed, you will do band ligation. There is no data whether adding non-selective beta blockers helps, but I suggest we should also give beta blockers. So three things we remember: patients who have got varices, beta blocker, carbidopa. Those who come with acute bleed, you have to do band ligation. And you can add non-selective beta blockers to reduce pressures in the future. Now, patients of AVB, acute variceal bleed, in cirrhosis with or without HCC, what is the outcome? In a patient, normally no HCC, there is a child acirrhosis and he has got clinically significant portal hypertension. He has not bled. His survival for 5 years may be 25 to 50%. Without clinically significant portal hypertension, 3 out of 4 cirrhotics will survive 5 years. Now, a patient has come of cirrhosis with HCC. He has bled. Now, compared to a cirrhosis, an acute variceal bleed, where survival can be 38 months. This, in the presence of HCC, decreases to 5 months. So 38 months, a cirrhotic with bleed can survive. But cirrhotic with HCC and bleed survives 5 months. I told you in active bleed, you will do band ligation plus glue therapy. If it is uncontrolled, an emergency tips despite portal vein thrombosis can be done. What is our aim? In acute bleed, we should try and increase 5 months to 2 years survival. We are not able to achieve, but our aim should be, that is, HCC and cirrhosis should live, after a bleed, should still live for 2 years. Now, can tips be done in a patient with HCC? This is a systematic review. 19 studies, 937 patients were taken. Half of the patients had less than 5 centimeter tumor, and those who have got had portal vein thrombosis had more portal hypertension. Tips resolved bleeding or ascites in 60% or more. It was more effective for controlling the bleeding. So you can do tips in a patient with PVT and HCC. There were no lethal complications. Encephalopathy developed in 15% to 30% within 3 months' time. There is a complete response to treatment for variceal bleed or ascites in 16% to 75%. And these patients could complete the anti-cancer treatment for HCC after placing tips. So tips helps in improving the reducing the bad effects of complications and allows the HCC treatment to be continued. Liver transplant could be done in these patients after placing tips in a large number of patients, at least 40% or so. So this review, which is published just recently, tells us tips is feasible, tips is beneficial, and can allow HCC therapy to be continued. Now I will briefly touch about hepatic and extrahepatic surgeries and influence of other therapies. Now, resection is a common therapy for HCC in cirrhosis. Resection can be done safely if the platelet count is above 100,000 and HVPG is less than 12, or there is a ICG retention of less than 15%, suggesting patient has a good functional reserve for the liver. And this patient, if it is high pressure or platelets are low, one can assess for tips after doing HVPG and maybe making an assessment. So TIPS can allow resection as well. Now, patient is on immune checkpoint inhibitor. What are the risks in a cirrhotic? In the Imbrave 150 study, acute varicose bleed was more frequent in HCC patients with portal vein thrombosis, 14%. But if no PVT, you can give atezolizumab and bevacizumab safely. Only 1% risk. But with PVT, it increased to 14%. However, before you start the combination therapy, atezo-beva, please screen for portal hypertension. Primary prophylaxis using non-selective beta blockers, carvedilol is mandatory. Then do endoscopy every 6 months because the pressures may increase or portal hypertension might worsen. And new regimens without bevacizumab are favored if the patient has blood or portal hypertension and there are high risk varices. If the patient develops a varicose bleed on atezo and beva, stop and do not start again beva. You continue with atezo alone. Bevacizumab has few problems. It delays the variceal ligation ulcers. So the ulcers don't heal. The bleed control can also be decreased. After stopping atezo and beva for 1 to 2 weeks, then we can do endoscopic ligation or TIPS or any such procedures. For 1 or 2 weeks, due to beva, there is a risk of bleeding. After 2 weeks of stopping, you can do EVL comfortably. So if there is an emergency, do EVL or EBL then and there. If it is elective, then wait for 2 weeks. After resection, you can start bevacizumab after 4 weeks' time. What is the effect of locoregional therapies on portal hypertension? TACE and TARE, they increase the HVPG, portal pressures. Therefore, it is suggested that be careful. If liver stiffness is above 16 and spleen stiffness above 22 and you operate, post-hepatectomy liver failure is more. It means these patients have portal hypertension and cirrhosis. In a patient with infiltrative HCC, the whole tissue is infiltrated and the portal vein, then there is a rapid progression of varices. Such patients must be carefully monitored. There is more acute variceal bleed. Now, a patient has got HCC, but the thrombosis is not tumor thrombosis. It is a patient who has got benign chloric thrombosis. Such patient was on anticoagulant. So on anticoagulant therapy, he develops HCC. Question is, should we stop anticoagulation before bevacizumab? So in patients who are on anticoagulants, then you may put them on low molecular weight heparin and do band ligation. Yes, you have to stop bevacizumab if you are giving low molecular weight heparin or anticoagulant. You will have to continue with anticoagulant so that non-tumor thrombus does not increase. And you monitor such patients with liver stiffness measurement, try to keep it below 25 and add beta blockers. So a non-tumor thrombus patient and HCC, you can start low molecular weight heparin, continue to prevent further progression. So let me give you my carry home messages. The assessment, the management of portal hypertension in HCC is a very new, very important and emerging area. Only recently, 2-3 years, we have started giving importance to it. So every HCC cirrhosis patients assess portal hypertension, do endoscopy for varices, assess platelets which should be above 100,000, measure liver and spleen stiffness, but do not rely on them totally if PVT is there. We must try to prevent the development of HCC in a cirrhotic and carvedilol prevents HCC development by almost 40%. Patients with high-risk varices or large varices, prophylaxis should be done in these patients, preferably by giving non-selective beta blocker. If patient has bled, prevent rebleeding in these patients. In an acute variceal bleed, do variceal band ligation and subsequently add beta blockers. A rescue tips for acute bleed can be done, and tips can also be done to prevent or treat ascites and rebleed. There is no risk of a spread of the tumor into other parts. Patients with HCC and portal hypertension, extrahepatic surgeries can be done if platelets are above 100,000 and HGPG is less than 12. If they are high, you can place a TIPS. And immune checkpoint inhibitors can precipitate EVL ulcer bleed, delay healing of EVL ulcers, hence stop bevacizumab, and now newer therapies without bevacizumab are required. With this, thank you once again to the chairpersons and to the organizers for having invited me, and to my very dear and respected friend Professor Omata for having organized as a chair, as a patron this conference. Thank you. Good wishes.
Thank you very much, Shiv Sarin.
Greetings from ILBS.
All right. Yes. Thanks. Any questions for these topics from the floor? You know, Shiv, that you talked a lot about the portal hypertension, EVL, non-selective beta blockers, all those procedures. Once you see those patients, we might be involved much. But profile of the patient so different. In other words, I'm in the upfront hospital with emergencies, but nowadays, when I graduated medical school, say 30, not 30, 53 years ago, there are plenty of patients. So when I took a look at your patients in your hospital about a week ago, the totally profile is different. In other words, our case is a majority Hep C, and now it's decreasing though. Usually they don't come with a portal hypertension or variceal bleedings, only the cancer, small silent cancers, and very rarely decompensated cirrhosis. So what's about the background of these patients? I understand non-viral, metabolic, alcoholic patients the majority. Is that the patients you are dealing with day-to-day basis? Is that true?
Thank you, Dr. Omata. This is true that the patient profile is different. We still see a lot of patients with variceal bleed, and an HCC with large varices is very common. HCC who comes with acute bleed is also common. So maybe we are seeing patients who are more advanced and have portal hypertension. So as a regular practice, these patients of metabolic liver disease or alcohol or hepatitis B, which is more common in India, we give beta blockers, manage portal hypertension, even if cirrhosis plus HCC is there.
You know, Dr. Sheena is just sitting in front, and may I ask him about how much percentage of patients actually using the beta blockers in your cases, in your hospitals? Just to tell you, the Shiv, that the situation in Japan, I'm asking the Dr. Sheena here.
Yeah. Actually, so I now follow maybe 600 of HCC cases, but I haven't prescribed any beta blocker for those patients.
Yes, so that's the situations, and so I think that's why we need the profile differences among area to area in Asia. I think you have a most decompensated patients, and then we are not having that many. So I think naturally the way of treat hepatocellular carcinoma should be quite different, and I really understand that. Any message to Japanese audience? Shiv Sarin from India. in that
Well,
context?
thank you. And I must say that I enjoyed the morning session. It was very educative, and all these are new areas. I think we have now a commitment to AHawk, which is a program where we would like the data from different parts of the Asia on liver cancers. And this meeting, we will have some new guidelines or suggestions. But I would like that Asia should have 20,000 patients with liver cancers in next 1 year. And we all from different parts of Asia will give our data to AHawk, which is led by Dr. Omata. There can be differences in the region, in etiology, management, and that is what we need so that the guidelines can be used all across Asia, whether it is MAFLD or it is Hep C or Hep B or alcohol. I think our data will lead the new guidelines on HCC. With that, thank you very much for inviting me.
Thank you very much. Actually, we collected the 2,000 cases. We are ready for to joining the data from your countries, and maybe we may ask the WHO to support that kind of the programs as you originally suggested. So we may talk about maybe by the time of the next spring when you come to Japan finally. All right. Thank you very much, Shiv.
Thank you. Thank you.
はい、どうもありがとうございました。
Thank you very much, chair and lecture.